We have two speakers today, Kat Worsnop and Summer Marion, who are going to be talking about a research project that they've been conducting. Kat, as most of you know, is an assistant professor in the School of Public Policy. She got her PhD in politics from Brandeis, and her research focuses on global governance in general, specifically international organizations in global health security, but she also has a number of related interests, including cooperation on climate change, human trafficking, and disaster response. Summer Marion is a research fellow at CISM in the School of Public Policy. She's also finishing up her PhD dissertation at Northeastern University about private foundations and how they engage with international organizations in health disasters, basically. The two of them are involved in a major cross-national project looking at how different countries make decisions about border measures during pandemics, and they're going to talk to us some about what they're finding today. So thank you.
Thank you, Nancy, and thanks everyone for being here. We really appreciate it. We know there is so much going on these days, so we're looking forward to talking with you today. Let me emphasize that what we're going to talk about is very much in progress, so we would welcome any comments. Please interrupt if you would like, but also definitely note your questions for afterwards and your comments. We're looking forward to that. So I'm Catherine Worsnop. As Nancy said, I'm here with Summer Marion. We are both going to tell you about this project that we have ongoing. I'm going to speak for a little bit first, and then Summer will come in afterwards. So let me, oops, I should share my slides, huh? Let's see. All right, can you see them? Yes, okay. Okay, so let me just tell you quickly about this project. As Nancy said, the project is looking at the use of cross-border measures during outbreaks, and specifically, obviously, during COVID-19. And we are doing a few things. We're first building and analyzing a data set of cross-border health measures. So we're looking at all of the measures that have been adopted by countries. We're using as a foundation a data set that's been developed by WHO and others. Then we are conducting systematic reviews of the evidence around cross-border health measures. And we're also carrying out some case studies of government decision-making. So we're looking at the US, Canada, and Hong Kong. And today we'll be talking a bit about the US case study. We've been kind of trying to engage in policy debates at WHO with CDC, and we have several published outputs so far. I'm happy to share those with anyone that's interested. The project is funded by Canada's New Frontiers and Research Fund, and it is a collaboration with Simon Fraser University, Hong Kong University, and the University of Maryland. At Simon Fraser, Kelly Lee is leading the project, and then we're also working with Karen Greppen at Hong Kong University. So today we're going to talk about two in-progress components of this project. The first is how WHO's international health regulations play into this issue right now. I have always been focused on the kind of governance and WHO side of the issue of cross-border health measures. So that's what I'm going to be talking about. Given all of the developments that we've seen during COVID-19, how can government compliance with WHO's IHR be understood and evaluated? And is there still any value in doing so? Summer is then going to talk a little bit about our US case study, and in particular, kind of what we're thinking is a potential central puzzle to look at, which is what explains similar border policies that were adopted during the early days of the Trump and Biden administrations. So we're going to talk about a few things. First, I'm going to just provide some brief background on the IHR, the International Health Regulations, how they treat cross-border health measures, and then how this all played out during COVID-19. I'll provide just some guidance, some context for WHO's guidance on cross-border health measures, and then discuss what our current thinking is in terms of how to evaluate compliance with the IHR during COVID. And I'll show you some preliminary findings and patterns that we've seen so far. And then Summer will talk about our US case study. So the IHR, WHO's international health regulations, these are the only set of regulations that exist that are meant to coordinate the global COVID-19, but also to other major outbreaks like H1N1 2009, or the Ebola crisis in 2014, the Zika outbreak. So they are the international agreement that is supposed to coordinate how countries and WHO respond to a major outbreak. They've existed in some form since the mid-1850s. They were formalized under WHO at its founding in the mid-1900s. And always at the center of this set of regulations has been this dual purpose to provide maximum protection from disease while minimizing interference in international traffic and trade. And this dual purpose really came from the early days of cooperation around infectious disease outbreaks. Basically, the early conventions in the 1850s were a product of major trading states being upset that there were so many different quarantine requirements that they had to comply with and deal with. So this economic harm and interference in international traffic has always been at the center of this set of regulations. And this dual goal has kind of morphed over time to be part of what's thought of as an effective response. So as to an outbreak. So as Lawrence Gostin has said, he's a kind of major figure in work on WHO. He said that this is a central part of global health. Trade and travel restrictions are bad. So this is just kind of a dogma that has existed in global health. And it's always been at the heart of the international health regulations. These were most recently revised after the 2003 SARS outbreak. So they were revised in 2005 and maintained this dual purpose. So how do they treat cross-border health measures? What are countries actually supposed to do? When WHO declares a public health emergency, like it did for COVID-19, countries are supposed to follow WHO's guidance about cross-border health measures, along with some other things, but our focus today obviously is on cross-border health measures. So they're supposed to follow WHO guidance. There are some exceptions to this. If countries want to impose measures beyond the ones WHO recommends, they need to make sure that they're not more restrictive than similarly effective alternatives. They're supposed to base their policies on scientific principles, evidence, and WHO guidance. And they're supposed to provide this rationale to WHO and then review measures within 3 months. So countries can decide not to follow WHO guidance, but they're supposed to follow this delineated process and base their policies on evidence. Okay, so how did this play out during COVID-19? At the beginning of the outbreak, when WHO declared this a public health emergency, so the outbreak had actually been going on for about a month at this point. The declaration was made on January 30th. WHO recommends against travel or trade restrictions. So they then explicitly remind governments of their commitments under IHR Article 43, that's what I just laid out, and reiterate this position on Twitter. In other venues, they send a very strong message that countries should not be limiting trade and movement. They should not be adopting border measures. This was actually one of the strongest statements, most explicit statements that they've made against these types of measures at the beginning of an outbreak. So the message was clear from WHO, countries should not be doing this. Why? So we now kind of look back at this recommendation and we see that so many countries have adopted these measures. They seem to be an important part of countries' response to outbreaks. Why did WHO make this recommendation? So the first component, there are many things going on, but likely the first component was that at the beginning of COVID-19, the way that evidence has been interpreted around these measures is that to suggest that they provide little public health benefit. During past outbreaks, travel measures in particular have been shown to potentially delay an outbreak, not by very long, but in general, outbreaks have not been prevented using these measures. So evidence had been interpreted to suggest that there was little public health benefit. At the same time, these measures are thought to be associated with a range of harms. So these are wide-ranging. They include imposing economic harm on governments that are trying to deal with an outbreak, decreasing trust in governments that are trying to deal with an outbreak, disincentivizing individuals from reporting symptoms, disincentivizing governments from reporting outbreaks because they might then be the target of costly trade and travel restrictions. So on the one hand, you have little public health benefit. On the other hand, potential harms that are wide-ranging. In spite of what seemed like clear evidence, though, governments continued to use border measures during outbreaks. So if you look at H1N1, here's a map of governments that imposed import restrictions on pork products during H1N1. About 25% of countries did this, even though WHO recommended against it, and countries were supposed to follow that guidance. Similarly, during the Ebola crisis of 2014, you had, again, about 25% of countries disregard WHO guidance and restrict travel from the 3 countries most affected by Ebola. So you have persistent behavior by governments imposing these measures, and then what WHO and others saw as little evidence in favor of their use. So given that, it starts to kind of make sense why, sorry, I'm flipping around, why WHO recommended against these measures at the beginning of the COVID-19 outbreak. They saw little benefit to them, and yet countries continue to use these. So a strong message had to be sent that this wasn't the right way to respond to this outbreak. Well, things have changed a bit. So it's always been difficult to kind of define legal compliance with that part of the IHR that I put up before. The language is vague, as you might have noticed, right? Interpreting whether countries have actually followed that process for imposing additional measures other than the ones WHO has recommended is hard. So it's always been difficult to do that. But this issue has gotten even more complex during COVID-19. So first, you have widespread adoption of border measures by governments. So every government imposed some type of border restriction in the first few months of the COVID-19 outbreak. So clearly these measures are becoming acceptable as policy tools to governments. Second, WHO itself actually softened its language in spite of its early strong statements. So by the end of February, WHO recognized that these measures might actually be useful in certain contexts. This was largely because there started to be a shifting evidence base about their utility. So first, some governments saw the use of these measures as critical to their success in minimizing the burden of COVID-19, and new research started to be done looking at the effectiveness of travel restrictions in the early phase of the outbreak, showing that it actually had shaped the trajectory of the outbreak and could lead to kind of delays in outbreaks starting in a given country, which could provide really necessary time to set up your domestic response. So these 3 kind of developments during COVID-19 has raised several questions. First, should WHO have made different recommendations at the outset? You know, this is obviously a question now. And then more broadly, is the dual purpose of the IHR even valid or useful anymore? Should reducing interference in international traffic and trade be a key goal of the regulations when it seems like for some countries, interfering in international traffic and trade has actually been critical to their response to COVID? And then third, how should we even think about government compliance behavior given this changed context? Is it meaningful to look at whether governments follow WHO guidance when that guidance might have been misplaced? And it's this third question that we're focusing on here in this part of the project. So as I said, there's always been challenges identifying legal compliance with the IHR, but now it's also very difficult to kind of define compliance with the spirit or the purpose of the IHR. And that would be trying to identify measures that actually provide public health protection while minimizing interference in international traffic. So it turns out that we know much less about both sides of that equation than we originally thought. There are gaps in the evidence when it comes to which measures actually provide public health protection, how we're defining public health protection. These measures and their utility may change over the course of an outbreak, and effectiveness depends a lot on other factors as well. On the other hand, it's also clear that we know little about the harms of these measures as well. When you look at the body of research on this topic, there isn't much documented about the range of harms that I mentioned. So both of the sides of this equation are unclear at this point. In addition, there now seems to be a gap between the two. So some countries adopted border measures that look non-compliant with their commitments to WHO and the IHR, and yet they seem to have been effective in helping these governments respond to COVID-19. So there's a disjuncture there. On the other hand, some governments imposed measures that maybe were legally compliant because they followed the process that I outlined above, and yet they may have unnecessarily interfered with international traffic and trade without providing a lot of public health protection. So there's a gap between the overall goal of the IHR and what legal compliance looks like, and it's hard to actually identify either of those things now. So given that, how can we think about government compliance behavior, and why should we even do that given this changed context and developments during COVID-19? So our preliminary thoughts on this are first to kind of identify a time when this gap between the purpose of the IHR and legal compliance was smallest. And we think that kind of the beginning of the outbreak, the early phase of COVID-19, is the best approximation of this, because the prior context was kind of still intact. Between the beginning of the outbreak on December 31st, 2019, and the end of February, WHO guidance hadn't changed. There was little known of new evidence about the effectiveness of these measures. Governments had no more reason than usual to distrust WHO guidance. So the previous context was largely in place. So we've decided to examine government policy decisions during this early phase and think of it as a good test of government commitments to the international health regulations and WHO on this question of cross-border health measures. We're looking at three kind of measures of compliance behavior. And I'm going to go through these quickly. Feel free to ask questions afterwards. But first is restrictiveness. So we're looking at whether a government imposed what we're calling a restrictive measure, and I'll show you what that is in a second, in the early phase of the outbreak. Then we're looking at basically what we're calling an interference score, which is the extent of restrictiveness. These first two measures are looking at basically the extent to which government measures interfere in international traffic. And restrictiveness is a binary measure. The interference score has 7 levels. So we're getting at kind of more detail on the extent to which governments are interfering in international traffic. Then we're looking at the timing of the first restrictive measure. So in short, the more restrictive measure that a government imposed, the more potentially non-compliant they were with the IHR. And the earlier they imposed such a measure, the quicker they were to kind of disregard their commitments to the international health regulations and WHO. So let me just show you some patterns. First, I'll mention the data we're using. So I mentioned we're using WHO's data that they've compiled from several sources on public health and social measures. They have a category of measures called international travel restrictions. We're using this as a starting point and building on it in several ways. But what's useful to note here is that they focus on 9 types of international travel measures. I've listed them here. The ones in blue are the more restrictive measures that I mentioned. So past research on this topic has counted these types of measures as potentially non-compliant because they actually prevent traffic rather than just placing conditions under which traffic can still occur. So we're focusing on these blue measures as the kind of more restrictive, potentially non-compliant measures. Okay, so let me just show you some preliminary findings here. So if we look at the restrictiveness of the first measures that governments imposed during this early phase, a 1 here is not imposing any border restriction during this early phase. A 2 is imposing one of the less restrictive measures. So that's a warning, travel advice, screening, or quarantine. And then a 3 is imposing one of the more restrictive measures, those measures in blue. So you can see most governments' first measures was a less restrictive measure here. About 40 or so governments imposed a restrictive measure as their first measure. Interestingly, by the end of the early phase, so by the end of February, though, almost half of governments had imposed one of the more restrictive measures. So here is the US. The US is coded in dark gray here for its entry restriction on travelers from China in early February. Okay, so then if we look at the interference score, so this interference score recognizes that restrictiveness of a measure, the extent to which it interferes in international traffic, is not just based on the type of measure, it's also based on several other things, including the targets of the measure. So for instance, some countries imposed an entry restriction on one country, some imposed an entry restriction on groups of countries, some imposed measures on all countries. So this breadth of the target also impacts the extent to which a measure interferes in international traffic. So we've created this score, and you can see that there's wide variation in the interference score of countries' first measures. So here again are countries that had not imposed any measure in the first phase. A 2 would be countries that imposed one of the less restrictive measures against one country, and most often it was China here in the early phase. A 3 would be countries that impose a less restrictive measure against a subset, some grouping of countries that they identified as high risk. And then a 4 would be countries that imposed a less restrictive measure against all countries. And then you get into the more restrictive measures here. So of the countries that imposed a restrictive measure as their first measure, most of those targeted one country, again, that's China, and then some targeted a subset of countries. There was no government that imposed a restrictive measure against all countries as their first measure in this early phase. But there's wide variation. Then also in timing here, we can see the timing of the first restrictive measure imposed by governments. Most governments that imposed a restrictive measure did so within this few-week time period here. WHO declared the public health emergency right around here. Okay, so what are some takeaways here? First, most governments' first border measures were generally compliant with the IHR. If we're thinking of compliance in terms of less restrictive versus more restrictive. However, about half of governments eventually adopted border policies that interfered in international traffic and were potentially non-compliant at the end of the early phase of the outbreak. There is wide variation in the extent to which these measures interfered with international traffic. So countries may have imposed measures that were potentially non-compliant, but the actual measures that they imposed varied a lot across countries. We also see, as I just said, that most governments adopted restrictive measures during a few weeks. So they seem to cluster in time. Lastly, our kind of conception of compliance here suggests that there might be limited overlap between measures that could be legally compliant and what we are now learning about what makes an effective measure. So in general, measures are more non-compliant the more they restrict international traffic, right? So that means the more restrictive measures and the measures that are broader in their targets. However, we've learned that at the outset of an outbreak of a virus that has the characteristics of SARS-CoV-2, more effective measures might actually be categorized as interfering more with international traffic. So we're learning now that more restrictive and broader measures at the beginning, earlier, actually might have been more effective from a public health perspective. But these are more non-compliant with the IHR. So there is limited overlap between compliance and what we're now learning about effectiveness, at least at the outset of an outbreak of an unknown virus. So our next step for this part of the project is basically to look at each of these takeaways and try to explain why there is variation across countries in the extent to which they adopted potentially non-compliant measures and when they did so. So that's our next step. And I'm going to hand it over to Summer to talk about the US case study.
Thanks, Kat. Okay. I'm just going to share my screen. Once you unshare yours, I think, Kat.
Oh, hold on.
Thanks. All right.
Okay.
Great. Okay, so in this phase of the presentation, what I'm going to do now is try to bring some of this into context for you in the US case. And so we're going to look briefly, not looking at all of the measures the US has imposed, but looking at critical subsets of those measures to give you sort of a good sampling of what has happened at measures imposed under both the Trump and Biden administrations, because of course the US gives us a great chance to look at the effect of electoral time horizons, among other things, since we had a presidential election last fall. So I'm going to make the case, and you know, Kat and I are making the case in this case study that we actually see quite similar border policy outcomes under both of these administrations. So I'm going to, as I walk you through these, again, relate them to some of the concepts that Kat has introduced and talk through why we believe this to be an interesting puzzle. All right. So to give you a sense of what happened under the Trump administration, first of all, we're going to look at some travel advisories that the US implemented. These advisories under Kat's framework that she presented would not be considered potentially non-compliant. These would be okay under the IHR. So on January 23rd, 2020, we had a State Department travel advisory level 4, do not travel, saying Americans should not travel to China. We had similar advisories imposed against countries where we saw high prevalence of SARS-CoV-2, either level 4, do not travel, or various types of elevated advisories in the following 2 months, February and March, followed by a global advisory in on March 19th. But again, these were all advisories. So again, they would not be considered restrictive measures. The first US restrictive measure was imposed actually just in that cluster, if you recall, on the graph Kat showed, just after the WHO declared a public health emergency of international concern on January 30th. So the first US restrictive measure was an entry restriction barring all foreign nationals present in China within the past 14 days. And this took effect on February 2nd, 2020, but was announced just after the public health emergency of international concern declaration. It's really important to note here, however, that we've seen copious evidence that this restriction was not particularly effective. So we had, both the exceptions to this restriction were many, and the enforcement was quite weak. So we did actually have a lot of travelers coming into the US from China in the subsequent time period. And so in terms of stopping imported cases, it didn't actually fulfill its purpose. Furthermore, we had similar restrictions between March and May of 2020. So again, the same policy, essentially the same language, was expanded to encompass other countries where we saw high prevalence of SARS-CoV-2. So these entry restrictions were expanded to include Iran, the Schengen area, the UK, and Brazil by May of 2020. And finally, we also saw what was framed as mutual land border closures on non-essential travel on the Canadian and Mexican borders, despite, in the case of Mexico, clear CDC opposition. And again, the enforcement of these measures, and this measure would also, like the previous measure, the enforcement of these measures is not considered or not found to be very effective. So what we see here in terms of the measures implemented during this early phase of the pandemic under the Trump administration is that in terms of the dual purpose of the IHR, they're kind of a lose-lose. We actually see that we have both a restrictive measure, so potential noncompliance with the IHR, but we don't see that these measures are implemented in a manner that is very effective. So to Kat's point about the changing evidence base for effectiveness of early travel measures, which we're beginning to understand with new evidence that's emerging, these measures, they wouldn't really fall under those potentially more effective early measures either. So moving on, let's look at what happened during the Biden transition. Leading up to Biden's inauguration in January of 2020, President Trump announced January of 2021, 2020 did not in fact last forever. President Trump announced that there would be a negative test requirement for incoming international air travelers to the United States. Beginning on January 26th, which was in fact after his administration would have left office and the Biden administration was to take office. For those of you interested, this is a negative antigen test or the rapid test, which is not as effective as a PCR test, which some countries have used. We also saw on January 18th, the Trump administration announced that they would rescind the measures they had implemented, the entry measures against Europe and Brazil on January 26th, again, after the Biden administration was to have taken office. But those against China and Iran would remain in place. So the Biden team had been quite critical of the measures implemented by Trump, in addition, of course, to many global health policy experts early in the pandemic. However, we saw an immediate reaction from the Biden team to this announcement that these restrictions would in fact remain in place after Biden took office. And in addition to this, on January 25th, in response to the new variant circulating, Biden announced that South Africa would be added to that list. And so we saw both the test requirement that Trump had announced kept in place, and we saw these entry restrictions, which we have deemed restrictive under the framework Kat explained, also kept in place and expanded in the early days of the Biden administration, despite prior criticism by Biden himself, among others, of these policies. And we did also see some changes under the Biden administration as well. So in addition to this, the Biden team announced a new a voluntary quarantine requirement, essentially, for incoming international travelers. But this was unevenly enforced, as was the testing requirement. We also saw the Biden team began a mandate coming from the federal level for mask wearing on airports and in airplanes. So again, this is something that had been called for quite a long time under the Trump administration. Most of these types of policies had been left to the states, and no action had been taken at the federal level. So the Biden team took these actions in their early days, but we saw very uneven enforcement, especially in the measures that might have mattered most. On April 19th, so just earlier this week, we saw the next change that we've seen since the very early days of the Biden administration to border measures. The State Department announced that Americans should not travel. They announced they were going to be rolling out these new level 4 travel advisories, so do not travel advisories aimed at American citizens, to up to 80% of countries globally. This was a change from 16%, which had been the previous level before this announcement on the 19th. So many of these have already gone into effect, but the announcement indicates more will continue to be rolled out in the coming days. And the rationale for this was reportedly that it would better align with CDC guidance and that it was not related to changes in epidemiological context. However, it's difficult to believe that it doesn't have to do with the growing vaccine inequity that we're seeing as more and more Americans become vaccinated and want to travel again internationally, in addition to new variants that continue to circulate. So it will be interesting to see how this plays out. Okay. Sorry. There we go. Okay, so are these actually similar approaches at the border? Have we made the case that this is a puzzle and that we actually do see this consistency across border policies under the approaches of both the Trump and Biden administrations? We argue yes. Both of these are focused on targeted and reactive entry restrictions. Reactive to cases or targeted against countries where we're already seeing high prevalence of SARS-CoV-2, and again more narrowly targeted. Sorry, I'm jumping around a bit. Not sure why it keeps going back to the previous slide. Okay. So Biden did implement, again, these changes in terms of quarantine and testing and mask wearing, but they were incredibly, or have been to this point, incredibly inconsistently enforced, especially the one that had the most potential to make a difference, which is the quarantine requirement. So what could Biden have done differently that would have made us say, yes, we do see a difference in the approach to the border under each of these administrations? First, Biden could have enforced or incentivized quarantine and tied it to testing, as we've seen in many other countries. So this could look something like a government-supported hotel quarantine, during which travelers are tested at set intervals over the course of the quarantine, or a quarantine that's enforced by tracking device, which has also been implemented in other countries. A secondary approach Biden could have taken would have been to take a broader, more proactive approach to entry restrictions, so more of a preventive approach, rather than reacting to new variants in circulation, for example, such as the new restriction against South Africa. Biden could have taken this approach, which has been successfully implemented in other countries, of implementing restrictions earlier and more preventively. So is this a puzzle? We would argue yes, it is. We see that Trump's approach was criticized by both Democrats, including Biden, as you see in this tweet, and public health scholars alike. And the Biden administration did, in fact, perpetuate many of the policies and did not change the overall border approach, as you see in this tweet below from, at the time, incoming Biden press secretary Jen Psaki on January 18th. And this tweet is in reference to the Biden administration's announcement that they would maintain the entry restrictions the Trump administration had chosen to rescind. So moving forward, our goal is to look across both administrations and to try to examine the extent to which each set of decision makers and agencies involved, of the extent and manner to which they cared about global and domestic epidemiological context. How did they internalize these into their decision-making processes, as well as international commitments, of course, including the IHR. We have to note, of course, in this case that it's very early in the Biden administration. And as Kat noted, when we look at the early set of measures, as she showed some of these preliminary results earlier, we know that the context was held relatively constant during that time period. And so the context through which the Biden administration's decisions were being made and they were filtering that information was also quite different. So some of the lenses that we are taking into account as we consider the different mechanisms which might have motivated these decisions include various approaches in international relations, electoral considerations and public pressure, including, for example, the electoral time horizon set by the 2020 US election, bureaucratic and interagency politics, for example, the marginalization of the CDC and their changing role, and consolidation of decision-making in the White House, changes in advice from WHO, as Kat discussed earlier, and how these changed and progressed over the course of the outbreak. Leadership background, socialization, and preferences across involved individuals and small groups of decision makers. Policy diffusion and policy learning. So we've seen a changing evidence base in terms of the utility of travel restrictions, and we've also seen changing norms. So how did that affect the decisions that were made by these decision makers? Also, path dependence and interplay between domestic policy responses and border policy. So as I discussed earlier, we saw in the first year of the pandemic, mostly under the Trump administration, many decisions about domestic policy related to restriction of movement were left to the states. So how did this interact with the Trump administration's approach to the border, and how did that carry over into the Biden administration? And finally, importantly, did the IHR matter? And if so, how? How was this international commitment taken into account by decision makers across each administration? So moving forward, our next steps for this project will be to explore these various approaches to understanding these decision outcomes through interviews with key stakeholders from both administrations beginning next month in May 2021, to continue to build and analyze the data set on border measures across countries over time, which Kat introduced, and to conduct follow-on systematic reviews of evidence regarding travel restrictions over the course of the pandemic. And finally, to better incorporate trade measures, which are at this point relatively underexplored in the data that we have. And so with that, I will stop and thank all of you again very much for coming. We're really looking forward to hearing your questions and feedback. Thank you so much.
Well, there we go. Thank the two of you very much. That was really interesting. One of the things that I'm really interested in is how you think of the effectiveness of the measures that were put in place. Because listening to you, it seemed that you were measuring effectiveness basically in terms of the enforcement of the measure. Whether or not they actually stopped people from a particular country coming in, as opposed to effectiveness of slowing the spread of COVID-19. Do you have any way of capturing that other part of effectiveness?
So yeah, I can kind of speak to this. So this has obviously been difficult to define. So in several ways. So yeah, you've talked about two different types of effectiveness. Obviously, one type of effectiveness looks at kind of did a border measure actually stop travelers, right? And that's potentially related to, but not necessarily the same as right. Did it affect the trajectory of the outbreak in any given place? So past studies of these measures have focused on a very small subset of public health outcomes. And normally they are delaying the start or the peak of an outbreak and then reducing the number of cases that are exported. So these are important measures of effectiveness. They're not the only ones, but they don't tend to, the public health studies don't tend to look at how many travelers were stopped. Other people look at that question, right. But obviously that question is kind of folded into looking at these public health outcomes, because if you're not stopping travelers, then one could probably assume that the measures are not affecting the public health outcomes. It's something else potentially going on. But the public health focus has been on those, kind of that set of public health measures. What has now been found about kind of the early phase of the outbreak, and that's what most of the research has focused on now, just because of the pace of research, is that they're still looking at those public health outcomes, but they are focusing on the timing. So the earlier the measure was imposed, the better it seems to be. Then the breadth, which is part of what I mentioned earlier. So when you don't know where an outbreak actually is, which actually happened to be the situation at the beginning of the COVID-19 outbreak, it doesn't make sense to target your measure. So all of the measures that were targeted at China were missing all of the other countries where the outbreak had already spread. But the other component on the type of measure that's most effective is that there's actually a lot more uncertainty, because that can be more related to what other measures you've also adopted domestically. And this is kind of the other missing part of how WHO talks about cross-border health measures. This has changed now for WHO, but back at the beginning, the border measures tend to be talked about, totally separately from the domestic measures. But of course, the effectiveness of both is related to the other. So it turns out that the value of border measures actually increases as your domestic measures get more effective, because a higher proportion of your potential cases could be coming from outside. So anyway, countries have been able to adopt different types of measures in effective ways. So some countries have relied on broad quarantines, for instance, that every traveler coming in has to quarantine and get tested periodically. And that has worked for them based on their domestic response. Others have adopted more restrictive measures, focused on the entry restriction type of measure, and have not, put in place this big quarantine and testing infrastructure for travelers. So you see different types of measures can be effective from a public health perspective, given other things that are in place and the way that they're implemented. I don't know if that gets at your question.
Yeah, I mean, it starts to. I was just trying to separate out in my mind, for example, if the bottom line really is that the WHO was wrong to have those recommendations in place to begin with, or if they do actually, how to measure if they make some degree of success, and whether keeping them in place, especially in the United States, after you have very widespread domestic spread, whether continuing to interrupt trade and travel actually buys you anything.
Right, that's the question. I see Summer wants to come in for a second. Let me finish with one thing and then I'll turn it over to you. So I think the bottom line is that travel measures can help, right? But under certain contexts and in certain conditions. So like the ones that were adopted in the US at the beginning, they were restrictive, and potentially could have done something. However, we're probably not the best ones for our context and situation. And so it's that nuance and context that needs to be more a part of the kind of recommendation process on which measures should be adopted. And we probably shouldn't have a system that's reliant on kind of a blanket recommendation for all countries, because context varies, of course.
Yeah, I just wanted to speak also more broadly, I think, to the question of what kind of effectiveness, which I heard, I think, embedded in your question, Nancy, and I think, Kat, you addressed it, but even stepping back more broadly, we talked about the dual purpose of the IHR, and the primary focus is, of course, preventing spread of disease while minimizing disruption of trade and travel. And Kat talked about the lack of evidence that exists on the externalities that are believed to occur if we disrupt trade and travel. For example, choking medical supply chains, perverse incentive structures for both governments and individuals, human rights violations, the list goes on. So the concerns that have been put out there. So I think from the outset of this project, a goal was to be able to address some of those other social outcomes of effectiveness. However, there are not good data on those right now. So when we discuss, for example, in the US case, when we discuss effectiveness, say, of the restrictive measure against China, we know there are data to show many travelers came into the US, as Kat said, during that time. So that's the best proxy that we have. But we're, of course, operating on a measure of effectiveness as defined by epidemiology, by imported cases. So that's primarily what we're able to address, at least quantitatively at this time. And we don't even have as good data in the US as some other countries do on specifically how many imported cases came in, because we're not quarantining and testing rigorously and regularly in an enforceable way. So I hope that provides a bit of additional context.
Oh, thanks. Let me open it up for questions from the audience. Rob, you look like you want to jump in. Unmute yourself.
Yeah, I'm at my best when I'm muted. So, not a question exactly, but some comments, if that's okay. Right. What there's so many lessons from this story, and they're still being learned. And many assumptions at the beginning were a little peculiar, and in retrospect look even more peculiar than they did at the time. The WHO, bless its heart, is a creature of the international state system. And so you have this potential for what I call neoclassical epidemiology, where trade and markets solve all problems, even in a pandemic. I mean, this was really peculiar. And we had this rather strange paradox of lockdowns domestically stay-at-home orders, combined with an insistence that we not interfere with trade. Well, you're interfering with trade enormously domestically, and that's obviously something to do, but not across a border, which just points to the status of international borders in international law. Also, travel risks are not just a function of foreign destination or foreign origin. They're also a function of travel itself. For instance, Trump's repatriation of Americans was a disaster. It was a concatenation of super spreader events in designated airports. Thousands of people lined up like sardines, no masks. One of the most interesting and tragic features of the past year, and we've seen this again and again and again, and we've seen almost nothing but this, is how few people have any sense of exponential growth. The time to intervene maximally is at the beginning. The notion that one should intervene incrementally to stop exponential growth demonstrates, a lack of schooling. What part of algebra did these people not, attend in high school? So what you really need to do in the countries, the most successful countries like Taiwan, did everything immediately and did it well. We as a country, the United States, were grudgingly responsive in every respect and did everything badly. Just a few other comments. Quarantines, the original infectious disease intervention. It's often necessary, and a lockdown is a quarantine, a stay-at-home order is a quarantine. It's not just, overseas. But there are lots of ironies. APHIS restricts plants and animals all the time. BSE, bovine spongiform encephalopathy, mad cow disease, was brought by trade to Britain. And it didn't get to Argentina because there was an embargo after the Falklands War.
Rob, can I just jump in for a second? Because I wanted to respond to a few things that you said. The first is I'll go in opposite order. So we're saying that Taiwan, for instance, had done everything very quickly and at once. And it's true that you see a lot of countries successfully do that. However, what's really interesting and something that we're planning to look at is there seems to be variation across countries in terms of this ratcheting up approach versus the all at once. And some of them have been able to be successful with the ratcheting up approach in a way that you might not have expected. So like Hong Kong, for example, has slowly ratcheted up its international travel restrictions when one would have thought, based on the exponential growth model, that you would have had to do it right away. So it's, I think, a real question. What allowed those places to still be successful with this ratcheting up approach? What did they do? They did domestically what they had to do very quickly.
Yeah, well, in terms of international trade, maybe, but as Nancy pointed out, in the case of the US, if you have heavily infected countries, then the period of time when you could get a big benefit from restricting international trade has probably passed because you're already heavily infected. And Hong Kong, is arguably or unarguably a part of China. So they were already, very close to the reactor.
No, sure, right. And
Yeah.
I think part of the explanation for why they were able to ratchet up on the international side is because they responded domestically so quickly and had been one of the earliest. Like they actually stopped travel with China very, very early, mainland, very, very early.
Well, and China stopped internal travel.
Well, yes. And that's, of course, something
I mean, that's
that many have not. So yeah,
we, and we saw that happening, and we're amazed.
right.
Well, a hospital in 10 days, just
Well,
all that. So they were stopping domestic travel.
Right. That's the other thing I wanted to go back to. So kind of this disjuncture between how international borders are treated versus domestic borders.
Right.
And that is so clear. They're treated so differently, and they
Sorry,
really,
I didn't hear that.
Sorry,
I didn't. You froze up.
I'm saying they really shouldn't be treated differently.
Right.
Travel is travel, regardless, and that's something that we're also kind of taking into account in this project. So we've been looking at studies on travel that look at both at subnational travel and international travel to actually learn more, from that perspective. But the other thing related to that point is that something else that I think must have factored into initial recommendations on international travel is that WHO and likely most countries in the world never thought that most countries would be willing to restrict domestic travel to the extent that they ended up doing. Like many of the assumptions about the so-called ineffectiveness of travel restrictions assumed that most countries wouldn't be able to implement strict travel restrictions or wouldn't be willing to.
Right.
When actually it turns out they are a lot more willing to do that than one might have thought, which potentially makes any type of travel restriction more possible and potentially useful during an outbreak. So I think we're in like an alternative universe that nobody ever imagined before.
Yeah.
And it's
right. And also the WHO has been abandoning its own lessons. I mean, ring vaccination for smallpox and all that. I mean, it's all about travel restrictions and Ebola, all about travel restrictions. But they became very timid.
Well, yeah, I mean, they're in a tough spot.
They're in a terrible position.
So let me jump in here on behalf of Davin, who's asked a couple of questions in the chat function that I've been monitoring. So the first is simply, when did China impose domestic movement limits and restrictions? And did this motivate IHR non-compliance at the international level? And the second is whether continuity across Trump-Biden administration, whether you've ruled out bureaucratic or other sub-state explanations for this non-compliance.
Thank you, Davin. I'm going to let Summer take the second question first if she wants to, and then I'll come back to the first question.
Yeah, thanks so much, Davin and Rob as well for these great questions and points. So to your second question, Davin, absolutely not. We certainly haven't ruled out bureaucratic politics and interagency type explanations. And in fact, this is an area in which we are particularly interested in gathering more data through these interviews we're about to conduct. So, one postulation could be, for example, we saw, and there's clear evidence of how the CDC, which is normally during an outbreak, especially a global outbreak, really the mouthpiece of the US government in many senses, was marginalized under the Trump administration, and decision-making was consolidated in the White House. And in the early days of the Biden administration, it appeared that decision-making was happening in a similar manner. And while, there were efforts to reintegrate the CDC, and I'm sure this is ongoing, as we're seeing, for example, with the new State Department travel advisories in coordination with CDC this week, there appeared to be some continuity there. So what does that tell you? from what we know about bureaucratic inertia, maybe it's really hard to heal an interagency system that's been broken or changed in that way. So we're definitely exploring explanations, basically, arguing that we might have seen different interagency processes or different bureaucratic processes under each administration, which led, despite the fact that they were divergent processes, to similar policy outcomes. So this is one line of reasoning in which we're very interested.
Yeah, that's a good question. Thank you, Davin. So your first question on the domestic movement. So China imposed the restriction on Wuhan and then others at the end of January. So I think starting like January 22nd or 3rd. And it's a good question, the potential relationship between that and IHR non-compliance. I mean, the two things I'll say on it. First is when China did that, it actually raised a lot of suspicions, right, around the world, because at the same time that China imposed those domestic restrictions, they were also saying that things were kind of coming under control. But it doesn't sound like things are coming under control if suddenly you shut down, your major cities. So at that point, suspicion increased globally that maybe we didn't know the whole story and maybe this was going to become more severe. And so I think it is possible, right? And we've seen this in the past, that when it has become clear that a government has not been fully open or transparent, that then leads other governments to, kind of overreact in this way. It's been looked at as overreaction before, the border restrictions, but definitely there could be a relationship there. And that's part of why we're looking at this variation over time in the number of countries that impose new measures. So that's one potential explanation. What makes it very difficult, obviously, is that a lot was happening right in that week. So you had and they're all related, obviously. So you had the internal restrictions in China, you had the WHO public health emergency declaration, and you had the news that there was actually human-to-human transmission a few days before that. So there was a lot going on, and obviously these were all related to one another. So we'll see what we can kind of tease out of the data we have, but obviously these questions are also what we're looking to get into in the case studies, and how did decision makers weigh these different events. And I see another question in the chat about potential consequences from Trump disconnecting from WHO and Biden reconnecting. Again, this is, a central part of our case study. We're trying to figure out what role, if any, relationships with WHO or commitments to the IHR played, what role they played in decision-making, if any. I think the Trump decision to withdraw, what was interesting is that from what I heard, a lot of US officials were still in close contact with WHO even after that official announcement. So I think it kind of goes back to who was actually making decisions during the Trump administration, and whether it was the people that were involved with WHO. So definitely we are looking into this. Summer, yeah, go ahead.
Yeah, I would just add to that. I mean, more broadly, you can look at variation in engagement in multilateralism across both administrations. So, of course, WHO and the events of last year related to U.S. membership are quite important to this case in particular. But also, we can see, despite the fact that we would make a case at this point that the policy outcomes in terms of border policy were relatively similar across both administrations, we did see really marked change when it came to rhetoric and multilateral engagement and re-engagement with traditional US allies, coordination with Europe, immediately around the inauguration. And so we can't say how exactly those actions relate to the outcomes we're studying. We can certainly make a lot of postulations, but again, as Kat said, this is something we're hoping to explore more in the case studies. And to the other point Kat raised, about the WHO withdrawal, this also goes back to individual leadership and small group decision-making explanations or lack thereof. I think I've heard from many sources that, Pompeo and most other senior officials were completely caught off guard by Trump's April 14th announcement at that press conference last year that he intended, to leave WHO or to draw back from WHO at that time. And so was this really the decision of one man with which, a lot of other agencies and individuals fell into line? And what effect does that have? So we can't say for certain, but we hope to learn more about this.
So speaking of that one man, what are you going to do about actions that were taken that, basically fit under your restrictive measures category, but seem to be motivated more by, his view of international security relations than anything related to public health? And here I'm thinking specifically of continuing to have, sort of special restrictions on people from China traveling to the United States long after China had, anywhere near the number of cases that you had in many countries that had no travel restrictions.
Mm-hmm. Yeah, I mean, this is central to us. So part of what we want to get out of both the cross-country analysis with the data set and the case studies is kind of weighing the role of public health information and the spread of the outbreak versus political factors. And those include, domestic political factors and also these geopolitical factors that might have shaped decision-making. Because what's clear is that potentially in the case of the US, but certainly for others, not all government's primary goal was, public health. It was something else, potentially, that they were using this situation as an excuse or, a good opportunity to further these other interests. And so which governments are most likely to do that, when and how, and can we see patterns across countries and over time? We're looking at that for sure. I mean, my past research has focused on the domestic political incentives that lead governments to put aside kind of public health goals. But in this case, there's clearly a geopolitical element as well. Yeah.
Well, I think this research is fascinating, and I particularly like the way you're trying to look at the interactions between basically these cross-border measures and how they interact with measures that are taken or not taken inside a given country. And I think that looking at that interplay has got to be incredibly complicated, but very important. So thanks a lot for sharing this work with us. I'll tell our listening audience that several of your recent publications are up on the CISM website already. And I know that there'll be more things coming out soon. So thanks very much to everybody who's joined us, and to Kat and Summer for a really interesting presentation.
Thank you, Nancy, and thanks everyone for being here. We appreciate it.
Good.